You are the Canadian Donation and Transplantation Research Program. You are CDTRP.
The CDTRP is a network of more than 400 clinicians, senior, mid, and early career researchers, trainees, patient, family, and donor partners, and 100 partner organizations. Our network has supported 275 collaborative research projects and has mobilized research into policy change, legislation, commercial products, and improved knowledge for patients, families, and donors. Every year, CDTRP supports between $30 to $40 million in grant applications, something around 60 to 70 individual applications. You are CDTRP. These achievements wouldn't be possible without your hard work.
CDTRP Research Services is a platform that supports principal investigators to develop high-quality research in donation and transplantation. We work hand-in-hand with CDTRP investigators to maximize the effectiveness of research teams through support with funding development, project management, patient, family, and donor partnership, knowledge mobilization, events, and trainee support. Across the 5 research themes, we help teams mobilize new knowledge to ensure patient, family, donors, healthcare systems, partners, and stakeholders equitably benefit from research results.
If you are a basic scientist and would like support with your knowledge mobilization plan, if you are a busy clinician scientist with limited time for research but would like to run a multi-site study, if you are an early career researcher and looking for collaborators to help with your grant applications, if you value patient, family, and donor engagement but are not sure how to find the right patient partners or what role they will have in your project, if you don't have full-time research staff but need support,
we are here to help. Our experienced management team can support you at every stage of your research in donation and transplantation.
Now you are probably thinking, how can I request CDTRP Research Services support? The answer is simple. Go to the CDTRP Research Services Platform website, fill out the form to request support, and we will get in touch with you to discuss your needs. That's it.
We.
No.
Noi.
Nos.
Emis.
Nosotros.
Menk.
Kiano. We. Kiano.
Our CDTRP, and we will drive research advances so that every wish to donate is fulfilled and transplantation becomes a lasting and sustainable cure.
You are CDTRP.
Email us today.
And for the next 40 minutes, we have 2 wonderful speakers lined up from both the Caribbean African Regenerative Medicine, CARM for short, the CARM project. So we have Dr.Jacqui Getfield, the project manager of the Caribbean African Regenerative Medicine, the CARM project. So Dr. Getfield is an adjunct professor in the Department of Graduate Studies at York University. She is the founder of Mothers United in Mediating Mutual Alliances. So through MUMMA, MUMMA, the mothers across Canada and internationally come together to discuss issues that are affecting them and their children with education and health spaces. So Dr. Getfield holds a doctorate of philosophy, a doctorate in philosophy and social justice education. And her research interests focus on family engagement, homeschool partnerships, as well as concepts of diversity, equity, inclusion, accessibility, and belonging, and diasporic living. Active in the Canadian Black community for decades, Dr. Jacqui Getfield is the founding member of the Jamaican Diaspora Canadian Foundation, and she was the inaugural executive director of the Alliance of Jamaican Alumni Association, the AJAA. Dr. Getfield will present on significant milestones in building community partnerships with the ACB communities across Ontario and online. And then we will pass it off to Osadolo, a third-year biomedical science student at the University of Guelph with a minor in Black Canadian Studies. And she's passionate about exploring the intersections of race and medicine, aiming to integrate this understanding into her future healthcare career. Osa will present on partnering with ACB communities, successes, and challenges. So with that, Dr. Getfield, I'll pass it over to you.
I applaud you for trying to say MUMMA, and it's MUMMA. Okay, so well, that's the diction. That's my diction as a Jamaican. It's MUMMA, but it's all good. It's all good. Good morning, everyone. Can everybody hear me? And thank you, Manuel, for putting up the first slide. First, let me thank the Canadian Donation and Transplantation Research Program, CDTRP, and I want to thank Manuel for inviting CARM to speak about our significant milestones in building partnerships with ACB communities across Ontario and online. Immediately after my presentation, as Chloe said, you will hear from Osa and Hayden. Hayden will be joining us, so he'll introduce himself at the appropriate time. And Osa and Hayden will be talking about partnering with ACB communities, successes and challenges. I hope somebody will be timing me so that I don't go over my 15 minutes. Yeah, so I want also to acknowledge the CARM project assistants who are in attendance at this virtual session, and especially to thank Kayla Ray Barnes for designing this PowerPoint, the PowerPoint that I'm using today. We'll be talking about CARM's journey from startup to today. We will be providing snippets of the conversations from our in-person conferences, and of course, we'll be talking about anti-Black racism in health, even as we introduce the project itself. And when I say the project, I mean the Caribbean African Regenerative Medicine Project. We call it CARM. From this point onwards, you'll hear me use the acronym CARM. So let's go back to the second slide where we have the Medicine by Design. Yes, CARM partners. We are funded by Medicine by Design at Temerity Faculty of Medicine, University of Toronto, and we are supported by the Jean Augustine Chair of Education, Community and Diaspora at York University and the Kidney Health Education and Research Group under the supervision of Dr. Iswan Muchi. Our partners in community health include CADO, Taibu, Black Creek Community Health Center, and among others. And we continue to build alliances with organizations such as CDTRP and health centers that serve Black communities across Ontario. In March, we had 2 fabulous in-person events. We connected with 4 more such organizations in Ottawa and Hamilton. So we are building our database of community health centers that look after the needs and focus on the needs of Black populations. So if all things are equal and we have money, we hope to be in Windsor and Kingston very soon. Stay tuned. Third slide, please. let's talk about the leadership team. So our project is led by Dr. Mucci, who is a transplant nephrologist and associate professor of medicine at the University of Toronto. And then you have Carl James, who is the Jean Augustine Chair in Education, Community, and Diaspora at York University. And of course, there's me. When I'm not teaching post-secondary, I do quite a bit of work in the community, specifically with Black mothers of children in the public school system. And that said, I work with mothers of all races who perform as agents and advocates on behalf of their disabled children in health and education spaces. I do this work through my support group called MUMMA. Now, what does MUMMA mean? It is Mothers United in Mediating Mutual Alliances. Let's talk about the investigators. In addition to the lead investigators, Dr. Iswan Mucci and Professor James, our team of co-investigators include Dr. Arjun Law, Sonia McParland, Paula Neves, and Nicole Woods. But I must give a special shout out about Dr. Arjun Law, because he is very active as a presenter at most of CARM's online and in-person conferences. He's fabulous. He explains the most complex subjects, complex phrases, complex concepts in very simple ways. And that is great for our the attendees at our community conferences. So our team of investigators really serve as an advisory board to CARM. So how did we begin and where are we now? Over years of treating members of the African, Caribbean, and Black communities, Dr. Iswan Mucci noticed that ACB patients, so African, Caribbean, Black, ACB, he noticed that ACB patients were not accessing healthcare and therefore did not benefit from treatments like how other members of mainstream patient communities seem to benefit. And we're talking specifically about white patients. He decided to do something about it. As lead investigator of what was to be called the Action Project, he conducted research in the ACB community. Professor James also collaborated with Dr. Mucci on the Action Project. Years later, with funding from Medicine by Design, under Dr. Mucci's leadership, CARM was created. So CARM began formally in January 2023. And as such, we are a very young project. We're practically in operation for just about 1.5 years. So I know you may be asking, what is regenerative medicine? Well, regenerative medicine is the process of placing, or I should say replacing, aging or damaged cells or tissues in the body with artificially created, fully functioning substitutes that will perform in the same way as healthy cells. One approach in regenerative medicine is stem cell therapy. Stem cell therapy causes the body's own natural healing agents to help support new tissue growth and healing. So what this means is that stem cell therapy could facilitate people being able to avoid surgery, right? People will heal faster and they will need less recovery time. Other approaches in regenerative medicine includes genes therapy, so genes therapy and organ transplantation. So why does CARM exist? First, we must consider what precipitated the need for us to create CARM. And I must be honest with you, our health systems and our health professionals have created barriers as a result of systemic racism, as well as individual discriminatory practices and prejudices. What resulted from that? Well, there is a persistent gap, a lack of trust between clinicians, health professionals generally, and members of the ACB communities. I listened attentively to Dr. Tate's presentation right before this, and it mirrors the concerns that we have in the African Caribbean Black communities. There is a lack of trust, and this lack of trust affects ACB patients and their families' ability to gather relevant information, their ability to advocate for themselves, and their ability to decide to become involved in research. But it's not one-sided, because there is a need for clinicians and researchers and health professionals to do their part to help ACB communities to build back trust. Aside from the trust, as we all know, there is a matter of cultural and religious differences that cause some members of the ACB communities to decline medical intervention. So as Dr. Tate rightly said, there are issues that happen outside of clinics that make an impact ACB patients and Indigenous patients' ability to perform in ways that health professionals and clinicians would prefer. So CARM exists because regenerative medicine is important to the ACB community. Consider this. There is a higher rate of chronic diseases. And by chronic diseases, I specifically gesture towards diabetes, hypertension, and cholesterol. There is the risk of kidney disease is 2 to 4 times higher in ACB communities compared to mainstream white communities. So when you think of that, then we will ask the question, what happens when a Black patient requires a kidney? Well, I must tell you, the probability of finding a match is dismal. African, Caribbean, and Black patients, compared to white patients with end-stage renal disease, are 65 to 69% less likely to receive living donor kidney transplants. Furthermore, African, Caribbean, and Black community members make up around 1.63% of the Canadian stem cell donor registry, and less than 1% of blood donors at the Canadian Blood Services identify as African, Caribbean, or Black. And I'll give you one more. Why does CARM exist? It exists because anti-Black racism is real. It is real, people, when I tell you it is real. Health professionals, clinicians, researchers must better understand the needs and realities of ACB communities. What is happening outside in the real world from day to day in these communities? All of us must intentionally address the health inequities, the prejudices, and the discriminatory practices in our system of health in Ontario and across Canada. Why must we do this? Because as regenerative medicine grows, the demand for stem cells, blood, will grow. So ACB communities must be brought up to speed. They must take advantage of the benefits of regenerative medicine. Stay right there, Manuel, thank you. And therefore address the racism and mistrust of the health system. We need folks to donate. This is especially problematic because diseases like sickle cell anemia disproportionately affect people of color. So we must reduce the barriers to donation so that ACB community members are encouraged to donate. This is the same for stem cell donations, bone marrow donations, etc. I will state the obvious again. If there are insufficient donations from a particular community, there will be insufficient products to respond to the demand. So how do we bridge the gap? Next slide, please. CARM's methods and methodology can be summed up in one sentence. CARM talks a lot. And by CARM, I really should admit that I talk a lot. But let us leave it in the plural. We deliver information and encourage extensive feedback during the QA sessions when we have conferences online or in person. Of course, we talk in one-on-one meetings when we introduce ourselves to various organizations, whether it's community health or it's community organizations or mainstream organizations. We do one-on-one meetings, we do group meetings. We engage in hospital settings, etc., etc. My point is we talk, we write, we present, we engage, we invite feedback, always. We do this not just with the ACB communities, but also with academic and scholarly communities as well. And of course, with the community of practitioners, of health professionals, including nurses, paraprofessionals, general and specialist doctors. And most importantly, we engage students enrolled in health sciences. So we're talking about undergraduate and graduate level students. Later, you'll hear Ossa and Hayden talk about the events that we had and maybe one or two quotes from the presenters and audience members. I'm telling you, that engagement in those two in-person conferences was phenomenal. You have to be there. We're going to put the slides up on the website. Right now, we're working on it. We're dissecting them so that people can access it in a more reasonable and in a way that makes sense. But let me tell you a little bit about our decolonial approach. CARM has inverted the power structure so that the data from the community, and when I say data, I mean the thoughts, perspectives, experiences of members of the ACB communities are as important as the medical and clinical information that is being shared by health professionals and subject experts. So at CARM, we make meaning, and therefore we make sense of our lives in relation with each other. So social interaction is paramount. The medical is also the social, but the personal is always political. Next slide, please. How do we serve? By now, you must have figured out that we talk a lot. Yeah, we had over 100 conversations with various people, organizations, individuals, community health organizations, mainstream organizations, you name it, we spoke to them. At first, we had decided just to reach out to community health organizations, in particular ACB community health organizations. But we were soon to learn that this was not going to be easy. In fact, in the first 9 months or so, our success was so sluggish that I decided, look, if we're going to have success, if we want success, if we want to have anything to report to our funders, we must change course. And so I decided to focus on building relationships and staging events with community organizations as well as community health organizations. So what does this mean? In the 16 months that we have been around, maybe by now it's a year and a half, so it's a little bit longer than that. So in the first 18 months, let's call it that, we had over 100 meetings with community health organizations, community organizations, and mainstream health organizations. And these meetings resulted in 10 events where we presented for, maybe about an hour, sometimes an hour and a half, during which we presented to about 200 persons or so. And we also, in this time period, specifically in March, actually, March 16 and March 26, we had 2 in-person events where we spoke with approximately 180 persons. And we continue to engage with organizations and to plan events with individuals of all ages. We partner with sickle cell organizations, with organizations like Donor Drive for Dorothy, ACB Organ Health, among others. And by doing so, we co-labor with these organizations and help to achieve their goals as well, their vision, their mission. So at CARM, we serve by engaging, we communicate, facilitate, interact. We amplify the voices of members of ACB communities by providing opportunities. Yes, we provide a platform for everyone to hear and share stories told by and in the voices of ACB patients and families. So that was the past up till to date. What are we going to do in the future? Moving forward, CARM hopes to stage 2 student-led events at York University and Queen's University. And these events will be coordinated by CARM students in collaboration with their student peers at the respective universities. We hope to have one more large in-person event, possibly in Windsor, Ontario, but it may just be in Kingston, who knows? So we hope to have one more in this coming year, and 6 virtual events with community health organizations, and in particular ACB community health organizations. So we're talking about places like Taibu, Cardo, Refuge, Urban Core, Somerset Health Center, and Black Creek Community Health Center. And lastly, we hope to have 2 partnership events. So let me wrap up quickly, because I know I'm running a little bit long. Evaluation and reflection. What have we seen? What have we learned? Well, the numbers tell the story. CARM has done well. I would say we get A+ for effort. But we must continue. We cannot just, relax. So we will continue to invest in building trusting partnerships, and we will give more time to bonding with community groups. We will ensure that when we go into communities, local speakers and participants from those communities will be the majority of persons who are addressing the problems or issues or concerns of that community. Time and time again, it has been explained to me that, even within Canada, different cities have different cultural realities. And so they are saying Ottawa is different from Hamilton, and things are done different from, what we do here in Toronto. And I get it. I'm a Canadian and I'm Jamaican. So I understand the importance of observing cultural differences. At this time, I'd like to say thank you and to hand over to Osa and Hayden, after which I invite you to engage with us in the Q&A sessions. Thank you. Bye-bye. Osa, Hayden.
Hello, everybody. I'm just gonna wait till we just set up for the screen. Hayden should be sharing his screen right now. Okay, and I'll start. So good afternoon, everyone. Thank you for the introduction. Hayden and I are excited to delve into our experiences in partnering with African, Caribbean, and Black communities. In our presentation, we'll be sharing our journey in coordinating 2 impactful in-person events held in Ottawa and Hamilton this past March. These events provided invaluable opportunities for community engagement and collaboration. They allowed us to deepen our connections and understanding within the ACB communities in Ottawa and Hamilton. Additionally, we'll be delving into the valuable insights we gained from the feedback of conference participants, as their voices and perspectives are instrumental in shaping our approaches and strategies moving forward. Next slide, please. Before we begin, I'd like to define some key terms that will be mentioned throughout our presentation. Sickle cell anemia is a genetic blood disorder characterized by blood cells that assume a sickle shape, causing various health complications. Systemic racism is discrimination or unequal treatment based on race that is embedded in the policies and practices of social and political institutions. Equity is the quality of being fair and impartial, often used in the context of ensuring equal opportunities and treatments for all individuals. And lastly, health literacy is the ability to obtain, read, understand, and use healthcare information to make appropriate health decisions and follow instructions for treatment. I will now hand it over to Hayden to introduce himself and speak on the Ottawa event.
Sorry, I'm just quickly going to share my screen again. Thank you so much, Osa, for that amazing introduction, and thank you again to CDTRP for having CARM invited. Just a little introduction about myself. I'm an incoming medical student at Queen's School of Medicine. I've been a part of the CARM team since this February, and I'm also a part of the Kidney Health Education Research Group for the summer. I'm very passionate about knowledge translation of patient experiences, so I'm currently going to be examining barriers to liver donor kidney transplantation among ACB Canadians. Moving forward, I plan to summarize the Ottawa event and all the amazing aspects of it. In the weeks leading up to the event, my role primarily involved database development, and with the 90 participants in attendance, we were very happy with the amazing turnout. So, this event was titled Building Trust, Confronting Anti-Black Racism in Health and Regenerative Medicine, and took place for an all-day event this past March in Nepean, Ottawa. This event was inclusive to community members, university students, and faculty, as well as high school students. And then in terms of its primary goal, this event was meant to be a networking and knowledge building opportunity aligned with CARM's mission to promote health equity, enhance well-being, and bridge the gap in regenerative medicine for ACB communities. Many of the focus areas included sickle cell anemia, chronic diseases, organ transplants, as well as regenerative medicine, of course. And then in terms of activities, there was health-related sessions and small group discussions. So I cannot go without saying these two patient speakers were probably the biggest takeaways, at least for myself, from the event. And I believe Charles Cook is in attendance at this session, so this is absolutely amazing. So falling in line with this focus of the forum, Charles Cook is a double organ transplant recipient of a heart and kidney, and Dorothy Vernon Brown is a leukemia survivor and stem cell donor recipient. Both of their speaker sessions exemplified the impactful role patients can have on inspiring future donors and invoking community change as a whole. Their stories in battling their respective diseases to now advocating for ACB communities is truly inspiring. And as examples, Charles Cook is now a member of the ACB Organ Health YouTube channel, which plans, co-creates, and helps promote engaging, informative, and trusted video content, supporting resources for ACB patients, caregivers, clinicians, and overall community. Then for Dorothy, she is the chair of the and marketing director of Donor for Dorothy, the first Black-led Canadian charity addressing underrepresentation of ACB individuals in Canada's National Stem Cell Registry. So, after a thorough review of the question and answer sessions, as well as the feedback provided by community members, 3 key themes emerged from the Ottawa event, being shifted perspectives, lack of representation in research, and continuity of CARM. And to start off, this is a perfect example of how just one of the many CARM participants, where perspectives absolutely changed following the event. They stated, "I think a lot of us sometimes in the ACB community, we have apprehension about donating anything, any part of our bodies, because we want to know that we will be cared for first, and secondly, that we can help someone else. So the idea that you would have given this explanation helps a lot, right? When it comes in terms of leaflets and things like that. So I think I'll do a bit more research, so I believe we'll be able to better understand." So just for context, this participant shared this following the regenerative medicine health expert presentations and is a testament to what CARM is meant to provide. A knowledge ground where people can plant seeds and then take this forward to not only spreading the knowledge to themselves, but also other community members. Now, falling in line with the focus of this forum, as CDTRP's mission is very strong in terms of strengthening clinical engagement of patients in clinical trials, as well as having an equity, diversity, and inclusive lens, a participant asked this very important question following our organ donation transplant sessions. They stated, "A lot of the diseases that you've talked about, women in my family have suffered from those diseases and illnesses, and they always end up going to the doctor and hearing the study was done, or diagnosing you upon the study that was done in these other areas, referring to the US, UK, and Europe, but never a Canadian study. Why is that? We also want to ensure that people who look like us, referring to the ACB communities, are part of this research and data, and they're doing it. So how do we get that done?" So, as you can imagine, this question was very multi-layered and required a lot of explanation. So thankfully, from our 3 CARM investigators, they provided an amazing response. They first highlighted that many organizations, including CDTRP, Ajmer's Transplant Center, Medicine by Design, etc., are actively working to expand Canada's participation in global medicine research. And then accounting for the second part of the question of lack of representation of ACB individuals, they first address historical factors. Research often lacks minority representation, especially Black communities, due to the systemic barriers and mistrust, leading to less relevant findings for these groups. And then they recognize community engagement, such as efforts by CARM, as a very effective solution, as through building trust through grassroots outreach, this can eventually yield to increased minority participation in clinical trials. And then putting the focus on researchers itself. They said there's a strong need for data transparency, as researchers must prioritize collecting and reporting racial data to ensure diverse and inclusive approaches to medical research. Now, for the third and final theme from the Ottawa CARM event is continuity of CARM. It's a great sign that attendees express a strong desire for the continuity of the work conducted by CARM, and they emphasize the need for more in-person and hybrid health events, which we are excited to provide. So in terms of some calls to action, participants had a strong desire for increased community collaboration and partnerships with health organizations and health researchers, They would love to hear more diverse health topics, including discussions of fibroids, endometriosis, and diabetes. And then they would like increased initiatives focused towards ACB youth, such as secondary student outreach programs. Thank you. And now, the Hamilton event.
So the sister event to the one in Ottawa, also titled Building Trust, Confronting Anti-Black Racism in Health and Regenerative Medicine, took place March 26 in Hamilton, Ontario. It aimed to address and combat anti-Black racism within healthcare and regenerative medicine fields. Through panel discussions, workshops, and presentations, participants engaged in dialogue and action-oriented sessions to confront systemic barriers, foster trust, and promote equity in healthcare for Black communities. I had the privilege of not only attending, but also assisting in the running of the event. I was able to assist with registration and also got to moderate one of the sessions. This hands-on experience provided me with invaluable insights into the complexities of addressing systemic racism in healthcare. Moreover, as a student volunteer, I gained first-hand experience in connecting with members of the ACB community. Next slide, please. The feedback and questions from participants in each of the sessions reflected two main themes, which was health literacy and anti-Black racism in healthcare. So for the first theme, which was health literacy, during one of the sessions in the event, a participant from the Ontario Renal Network raised a crucial point about patient care. They stated, "I'm here on behalf of the Ontario Renal Network. We hear from our patients that the nephrology community does not do a good job talking about fertility preservation and about goals of care in the context of family planning. Would you say that is consistent with your experience?" Her question was directed to Fadia Smith, who shared her experience as a transplant recipient. In response to this important concern, Fadia reported that initially there was no conversation with her doctor about her kidney condition. She felt as if her doctor was merely giving her instructions without any explanation as to why. Her husband had to advocate on her behalf, and together they had to press their doctor with questions until they finally understood the situation. Fadia's response highlights several critical issues related to health literacy, which applies to nephrology, but also to the entire healthcare system. Firstly, Fadia's account reveals that there are barriers that hinder effective communication between healthcare providers and patients. The lack of initial discussions about fertility and the late, unclear communications experienced point to an issue within the healthcare system that often goes unrecognized. Secondly, Fadia's experience illustrates the need for improved communication protocols. Healthcare providers must prioritize clear and comprehensive communication about medical conditions and treatment implications. Providing thorough explanations that cover essential topics such as medication effects, disease prognosis, and specific health concerns like fertility preservation will empower patients to make informed decisions. Additionally, healthcare providers should be trained to understand and respect diverse cultural backgrounds, as culture can impact health beliefs and communication. The second theme, as mentioned earlier, was anti-Black racism in healthcare. The last session of the event was a fireside chat moderated by Dr. Getfield. The session was initiated with a thought-provoking question aimed at one of the panelists, Dr. Juliet Daniel. Dr. Getfield asked, "So, Dr. Daniel, why would doctors, white or Black, be concerned about concepts of whiteness or Blackness when we are told that there is no difference between a white body and a Black body? The physiology and biology is divorced from the realities of the Black body, or what we sociologists deem Blackness. Why should doctors be concerned about whiteness and Blackness?" In response, Dr. Daniel provided a very comprehensive answer. She stated, they should be concerned because they took that Hippocratic oath, which is to do no harm, and they all know that there's a difference in the way individuals respond to drugs. They should have learned it in medical school. They're choosing willful ignorance. I think they're doing a disservice to their patients if they're not keeping up with literature. Yes, we're 99.9% identical genetically, but one mutation can determine whether your eyes are blue or brown. Every medical school should be teaching their students about these health inequities. We know that certain communities have higher levels of diabetes, heart disease, and stroke, so I think it's willful ignorance to brush it off and say that we don't see color. Dr. Daniel's response highlights several critical issues related to anti-Black racism in healthcare. Understanding inequities that disproportionately affect Black communities is crucial for healthcare providers to address systemic racism effectively. Medical education must include comprehensive training on the diversity of human beings, including how different communities are impacted by various health conditions. This includes understanding genetic variations and the implications for treatment responses. Engaging with ACB communities to understand their specific health needs and challenges is essential. This involves creating platforms for open dialogue where community members can share their experiences and advocate for better healthcare practices, which is what the Hamilton and Ottawa event aim to achieve. Increasing the representation of Black individuals in medical schools can help address biases and improve the cultural competency of healthcare providers. Diverse representation ensures that different perspectives are considered in medical training and practice, leading to more equitable healthcare. And lastly, Dr. Daniel critiques the notion of treating all patients the same without acknowledging their unique needs and backgrounds. Challenging this colorblind ideology is essential for providing equitable care. Healthcare providers must recognize and address their biases to ensure that all patients receive appropriate and effective treatment. That concludes our presentation. Thank you for your time, and I hope the information we shared was insightful. Are there any questions?
Thanks for those very, very excellent presentations. Very, very much appreciated. I do have a question that did come here in the chat, and it asks, what does the audience deem to be the best strategies to ensure their voices are heard regardless of their skin, color of skin? So that's an open question, comment to the audience. Anybody wants to jump in? Sandra, I see you have your hand up.
Yeah, well, being a white woman, I probably shouldn't answer this question, but I think working in enough research projects, I've learned that access to, first of all, getting diagnosed for the need for a kidney transplant is limited into, certain groups. I also know that, like if you look at on the blood work, the way the GFR was being done for certain groups wasn't fair, and they've been looking at that as well. And just, from working with Dr. Mushi on other things as well, is that different cultures have ways of how education is got to them. So for example, when we were just promoting organ and tissue donation with the South Asian group, and then there was another group that we worked with as well. It's who they communicate. So for example, in the South Asian group, they had to get permission from the elders to move forward. So now we have this amazing group called Arma Karma that does amazing work in that as well. But there's still a lot of problems with, and just in all communities, about health literacy and how to get access to things. And until you get to the right specialists as well. And it's being able to advocate, right? So having groups that, like the ones that we're presenting today, to empower people within their community to ask the right questions and to advocate for themselves, because that's how we get access to healthcare. It's a sad reality, but that's what it is right now.
Thanks for that, Sandra. I have a couple of other questions coming here through the chat. This is for speakers. Are you finding that the medical community is responsive to the needs of the ACB community, both within regenerative medicine and in the work that you're doing within organ donation and transplantation?
Well, I'll take a stab at that. The medical community is as responsive as it can be, only if they were trained, only if they understand. It's like, it's like a different language. It's a whole different language. And regardless of skin color, I have noticed the color of people's skin. That is not as important as their heart. Because as I mentioned, this CARM project and the Action Project are led by or initiated by Dr. Mucci, who is a white Hungarian. So it's not so much a skin color issue or a complexion issue. It's a matter of how much do we care? How much do we care about our patients? How much do we care about a group or a community of peoples who have been historically and traditionally disadvantaged? Do we care? That is the real question. And it is related to the question I see in the chat, which says, if health equity is not a priority concern for health professionals or clinicians or researchers, if it's not a concern in teacher training institutions, then where do we go from here? When that becomes a concern, when how people live and how they can access or not access the cultural realities, the socioeconomic realities, when those things are always put to the back burner and are not considered by the more powerful in our society, then we'll always be asking these questions. I hope that answered it.
Yeah, no, that's excellent. I really appreciate that reflection and oh, I have I see one more hand. Patricia, go for it.
Thanks very much, and thanks to all the speakers for really interesting talks. I was particularly struck by the exchange that was presented in one of the presentations, with the response being, one of the reasons to think about diversity of patients is because we know that different individuals respond differently to drugs. And I also see funders very keenly promoting the idea of health equity and funding studies in this area, both from a socioeconomic perspective, but also a biological perspective. And I wondered how the presenters felt about the risk of muddling the socioeconomic conditions that lead to health inequities and the genetic differences, biological differences in certain subpopulations, and muddling that with sort of what's race and what's genetic differences that have impact on response to treatment, for example, or risk for certain conditions. I mean, sorry, a little bit rambling question, if that was clear.
Very good question, but can I push back a bit and maybe ask for clarification? How does one respond in terms of treatment and without looking at genetic differences? And how do you respond without looking at the socioeconomic differences? I approach what we do through an intersectionality lens, and because I cannot see how you're going to divorce one from the other. In fact, that's exactly what the challenge is to clinicians and health professionals and researchers. How do we look at the psychosocial? How do we also look at the socioeconomic? How do we also look at the biological and genetic differences? Because nothing is divorced from the other. It is one being, one person that you're trying to treat. So how do you not do that? No, the flip side to that question is, will you use any of these to then present a deficit response to say that because this person doesn't come to appointments, then it means that they are disengaged? As opposed to saying, why were they disengaged? Are they seemingly disengaged? What's happening, as Dr. Tate alluded, what's happening in their lives? Why they're not coming to their appointments, or they're not taking their medication, or, we cannot assume that they don't want to live. So what exactly is happening? Are they doing their best, but there are things biologically that we don't know about that we need to do more research? I have no idea. I'm not a natural scientist or a health professional. I'm a social scientist. So we ask these questions that say that essentially probe beyond the obvious, because sometimes it's obvious to the person who is asking the question, but the person that the question is being asked about is so confused that they don't even know what's going on. So to answer your question in a nutshell, I think all things must be considered, and that's the challenge, because doctors generally, researchers, the health sciences generally have not been teaching how do we consider the whole person rather than just the biological differences. So somewhere in there is a response, Patricia.
No,
it's like your question.
That was a great response. I think my takeaway from your answer is that looking at just biological factors, for example, in response to treatments in different types of groups, it's not good enough. It's not good enough. We need to understand all of these other factors that are leading to those outcomes at the same time. We can't separate those things.
Right.
Okay. Can I jump in and cut you off now? I apologize. We have to move on to the next session.
Okay, no problem.
Thank you so much, Dr. Getfield, and Osa and Hayden as well. It's an awesome presentation.
Thank you. Thank you for having us.
Thank you.